Do you mind if I add?
Oh, sure.
Mary Cantwell, DHCS. The other thing I would add, as Jennifer mentioned, we do have in our waiver proposals that are looking exactly at this. How do we best utilize any funding that we would be getting through the waiver? And the idea being, instead of, as Jennifer said, just a rate increase, how do we actually have the payments go only to providers who are doing more services to Medi-Cal? And that's really then every single cent is expanding access, because it's only going to the extent a provider is new to Medi-Cal or taking more Medi-Cal patients.
Dr. Wood.
Yeah, just a quick follow-up, and I want to say I appreciate the emphasis on what you were just speaking about, but also streamlining the system and as it works, because that is one of the real impediments for providers when it's difficult to manage to work through the system to actually get compensated for the care they actually provide. It's a huge deterrent to continue to want to be a part of that system. So I appreciate that you're looking to streamline some of those things, and I think that will make a big difference in combination with some of these other actions. So thank you.
Thank you. I think we're ready to move to the next panel. So thank you to our presenters. I think some of the presenters in this panel are on our next panel. So all of you are. So we're just changing the subject here. So we're going to move on to the managed care organization tax topic. And before we do so, I want to make an amendment to some earlier comments I made about public comment. We will be taking public comment today. I understand that there are some individuals from members of the public who have traveled some distance to be here and want to provide an opportunity for those and anyone else who wants to make public comment to give public comment today. So, and we did not communicate in as robust a way as I had hoped that we would not be. So we will be. We will be taking public comment at the conclusion of the panelists' presentations. So moving on to the managed care organization tax, we have Mike Wilkening and Jennifer Mary Cantwell. MCO tax.
Sure. Mary Cantwell, Department of Healthcare Services. So I'll just briefly talk a little bit about why we're in the situation we're in and what the governor has proposed since January. All of it very well laid out in the background paper. We have had some version of a managed care tax for over a decade, and it's really helped to fund the Medi-Cal program. First, actually funding, helping to fund the Healthy Families Program, and now funding Medi-Cal managed care. The tax has always just been applied to Medi-Cal managed care plans, and through, as been described earlier, the actuarial rate setting process, the plans then were paid for the cost of that tax, and so it was really a neutral tax to the health plans that were paying the tax. Last July, the federal government sent a letter to all states. There are several others who have taxes like ours, indicating that taxes that are structured that are only applying to Medicaid programs are not permissible and that they would need to be revised. What they're relying on is their federal regulations on provider taxes and viewing managed care taxes as provider taxes. So the rules under provider taxes say that the tax needs to be broad-based and uniform across all providers of that service. So in that case, really all health plan providers in the state. And so the tax that we have proposed in the January budget and continues to be our proposal is an attempt to meet the federal requirements while also minimizing the overall impact, since now for the first time our tax would include commercial health plans and essentially be taxing non-Medi-Cal business, whether it's a new plan being taxed because they don't provide Medi-Cal, or even a Medi-Cal managed care plan that also provides commercial business. They're going to be being taxed for the first time on that commercial business. So the tax we've proposed was really aimed at achieving the goals of the funding levels. As has been discussed, the current tax does provide $1.1 billion of funding for the Medi-Cal program. In addition, it is a funding source that has been identified for the restoration of the 7% reduction in IHSS, which is about $220 million. So in total, we were looking for a tax that would generate overall essentially $1.3 billion of general fund that we would be able to continue to provide the same services that are being provided today. In order to do that, we, again, needed to meet the federal rules, and so we developed a tiered tax structure that is based on the number of enrollees, and the amount of tax varies based on the size of the health plan. That was really done to try to, as much as possible, still focus the tax on the Medi-Cal business, where, again, that's a net neutral to the health plan. It's not a net tax. But we knew we would have to have some amount of tax that was coming from non-Medi-Cal business. So the tiers were really structured to try to accomplish that. What that has resulted in is a tax that, although it generates in net $1.3 billion, the money that we need to fund the programs, the net impact to health plans is about $650 million. So we were successful in targeting most of that to the Medi-Cal plans, but still a significant cost to non-Medi-Cal business and to commercial plans. Overall, the net impact is a little less than 0.5% of revenue, but we also acknowledge that because it's a tiered structure, that actually varies from plans who are only Medi-Cal to 0% net impact because they, again, receive the tax back, to close to 4% for some plans, and we know that that's been part of the struggle and part of the conversation. We've continued to say that we are open to different structures that still achieve the same goals of meeting federal requirements and raising the funding that's necessary, and so we've had conversations with our health plan partners and continue to have them to see if there are other structures that make sense. But obviously we do think our proposal does meet those requirements, and so really trying to focus on how do we get there in a way that, again, does not have a huge impact on health plans, but still is raising the $1.3 billion that we need to raise.
And any more presentation? Okay, questions or comments from members? Assemblymember Levine.
Yeah, thank you very much for that presentation. Brief, but had all the information that we needed, and that's how I like it. First of all, I think that this is a huge problem, and everyone's acknowledged that. It's interesting that we're not the only state that has that, and that's it's good to acknowledge. In that many states developed something that didn't meet those federal guidelines. So I think it's great also that you developed a proposal to resolve all of this. There has to be an idea set forth to try to figure out how we resolve this problem. How do we end up with an MCO tax that works for California? And any proposal that is brought forth is going to receive criticism. Something of this magnitude and will affect us the way that it does. And so just acknowledging that it was really important for this idea to be put forward. And so can you describe some of the criticism that it has received so we can really understand that?
Absolutely.
Yeah.
So I think the most significant being sort of once everyone understands that there is going to be an impact. This is going to be a tax on commercial business. Obviously, if we could have structured it another way, we would have. The most significant has really focused on the tiered structure of the tax. And as I mentioned, we acknowledge there is a differential impact given some art plans are only Medi-Cal, and then given that it's tiered based on enrollment, that it can range from anywhere from 0 to 4%. And so that has been concerns have been raised about what impact that could have on the marketplace and the competitive market for health plan services. And it's why we've continued to say that if there are other options out there, we are happy to work on them. One of the suggestions has been a flat tax, which is an option. So it could resolve some of those discrepancies of not having as much of a range of impact. But that also has its own challenges. A version of a flat tax would, at the end of the day, have a larger net impact across the health plan industry because, again, one of our goals was to try to keep the overall impact down. As I mentioned, about $658 million net impact. A flat tax would likely be in the range of $950 million net impact to still get us the $1.3 billion. So those are the trade-offs. There would be plans who would have less of a tax under a flat tax compared to ours, and plans who would have more. And so, there are always going to be those challenges, but we continue to be open to talking about those kinds of structures.
Yeah, and as a follow-up, one of the things about the MCO tax, as where people are talking about it now, is that there's a more reliable funding source for things that we want to fund. So is there a difference in reliability between those two ideas that you mentioned? And then in the tiered structure, what happens when plans on different tiers merge, and that's occurring a great deal in the marketplace? How do they figure that out?
Now I don't remember your first question.
The reliability of the funding stream, yeah.
No, I don't think there's a difference in reliability. I think, there have been questions raised by the LAO about how often you would need to adjust something if it was a tiered structure, and certainly it would be something we would have to track more closely. But to the degree we are out of a time where enrollment changes drastically, obviously during the ACA sort of initial period, enrollment was changing significantly for plans, but at least what we're seeing is a little bit more stability. So that would be something we'd have to continue to track. Thank you, mergers. With respect to the mergers, so the way that the tax works is that a health plan isn't only in one tier. Our proposal is that every health plan for their first, I forget what it is, 150,000 members pays a certain level. So that's every health plan pays that first dollar amount. And then if they have business above that, there's another tier where then for that second tier of enrollment, there's a different dollar amount. And so what would happen is if a plan gets bigger or smaller, they would just be adding members at the level of the tier that they're at until you're at the highest tier, and then it's just more members at the highest tier. It would certainly impact the overall tax for that health plan, given the tiered structure. Once you get over a certain number, I think it's 2.5 million member months in a quarter, the tax for every additional member is 75 cents. So once you're in that highest tier, every additional member is 75 cents. So if a merger takes two plans who together are only paying through tiers 1 through 3, the likelihood is they would now be paying a tax at the tax at the highest tier. So it would overall likely bring the combined total of the tax. If you had two plans that merged, the tax that the two plans were paying would have been a higher amount in total than the single plan would be paying as a merged company.
Thank you.
Sure.
So thank you for the overview. And you indicated that the administration had a proposal. It was shared with stakeholders. My understanding is that there wasn't a warm embracing of that proposal. And you've indicated that you're open to other proposals. But I want to sort of frame this question a different way. Where do you think it needs to go to get more broad buy-in from the stakeholders?
Well, I think, we have been in discussions with the plans over the last several months. I think that they have been cooperative partners, right? The tax that we have as a proposal from the administration is certainly significant, and it is hard and challenging on a couple particular plans, just given their size and market share in the California area. And so I would say that they are still kind of running through some of their ideas, in that we have, heard that there are various interests in, is there a way to do, offsets of certain populations, or if we have, business in a different line, does that actually count? And so I think that we are still positively encouraged by the fact that the plans are even still wanting to talk to us, even the ones that don't do Medi-Cal today and won't do Medi-Cal in the future, right? They're small regional plans that do mostly small group or something like that. Even those plans are saying, we're, wanting to try to work with you. And so I wouldn't say that, we're frustrated. It's just really hard. And the first tax that we did, under the gross premiums tax was difficult in a different way. And so I think that we will get there eventually, but I think it also just means that, there's a path, and we just haven't quite hit that right magic spot. I mean, the thing that has to be done, though, because it's a provider tax, is it has to meet all the federal tests, which we've never had to do before, which makes it more challenging. And there cannot be a hold harmless. So those are some of the kind of barriers that preclude us from doing, a tax that would maybe be a little bit more easy to negotiate if there was ways to move money in a way that helps kind of offset some of their losses. And so those are some of the federal rules that they intentionally put up to keep states from doing exactly what we would do naturally. So I think we'll get there, but it's just going to take a while. Thank you.
In terms of the timeline, and it taking a while, Can you share what CMS indicated their deadline was for coming up with an alternative proposal, but also what the administration considers the timeline for getting to a agreed upon MCO tax?
Sure. So the letter from the federal government, again, went to all states. So California was not the only one. The letter specified that states had to deal with this by the end of their next legislative session. So this letter came to us last July. So the interpretation being that we would have to deal with it. It happens to coincide with the expiration of our existing MCO tax, which is the end of next June. Our position as the administration has been, if we go into a January budget with a hole, with a tax that is not existing, we will have to be dealing with a budget that does not have $1 billion in funding the Medi-Cal program. And so from our perspective, this is something that needs to be dealt with before that January budget.
Thank you. And can you also comment on the likelihood or unlikelihood of the federal government changing their position or providing any relief?
Sure. My belief is that it's not at all likely that the federal government will change their position. One of the things that we believe triggered a formal letter coming was a case in the state of Pennsylvania where the OIG came in and found a tax very similar to ours as violating federal law. And so that is what significantly triggered CMS to issue the guidance to all states who had taxes like Pennsylvania's to address that issue.
Assemblymember Bonilla.
And this could be completely, a silly question to ask, but when you talked about is the federal government, is there any flexibility there? It just reminded me, given the fact that our federal match is so much lower than other states, is that correct in California?
Certainly, there are other states who have a match similar to ours, but the average FMAP is significantly higher than what California's is. And
it just seems to me, I think maybe they're seen as completely unrelated, but it seems like we have this bigger gap to fill because of that, and there's no calculation from the federal government that perhaps that should be figured in when they're looking at us struggling to close that gap.
Sure. No, they do view them as separate issues. That there are certain laws that govern the calculation of the federal matching percentage. That is CMS is implementing those, and that there are specific federal laws and regulations about how provider taxes have to be structured. And so they do not view a connection there. That states are obligated to provide actually approvable matches of non-federal share. We do that through various structures. States don't have to do that through provider taxes; those are optional, and so they don't actually view that as a connection.
But and we have, I guess the rate it is lower, but it's based on our overall income in the state, and so it just seems to me, that. I don't know, it doesn't seem fair that we're getting, this lower match, and then, we're also on top of that now having to close a bigger gap with, coming up with some kind of solution for the state share. So I understand, it's very different, but it just, in the context, that's frustrating.
Absolutely.
And it seems to me there is an opportunity there where there's no other way to ever deal with the federal government to get our reimbursement rates higher. It would be nice if they would consider this as perhaps one avenue to give us some kind of a break. But thank you.
Absolutely.
Assemblymember Santiago.
Sure. Thank you very much for the presentation today. I very much appreciate it. And when I took a look at the first kind of fee structure or tax structure, it was concerning to me, and I was struggling to try to kind of figure out how we create a tax structure that doesn't create winners and losers while trying to balance a sensitivity to increases to anyone, because ultimately they go on to consumers. So I struggle with all those different concepts at the same time. But back to the point of mergers, if there was a merger in the future, it could reduce ultimately, at least at surface, when I'm looking at it at surface without much analyzation, I tend to look at if there was a merger, it probably would reduce the overall a payment into a particular pot that we could that would reduce probably our federal allocation of dollars given to us, and whether that's true or not, and whether it would take legislative action down the line to offset the numbers, or it could be done administratively. My guess is legislative action, but which would probably make it tougher because these are always difficult conversations to have. But I'd also like to know a little bit maybe about the rationale for how the fee structures were set, if there could be some clarity on that, because certainly when we're going about this new structure for an MCO tax, there are some plan providers who have lives within the Medi-Cal system, but then there are some who don't, and trying to grapple with how that, what the rationalization is for that. And if there might be any mechanisms to offset that heavy burden, because ultimately the concern is that it goes to the consumer. And I don't know within what parameters or frameworks some creative thinking can happen to do that.
Sure. So first, with respect to the merger question and what would be done under the structure we've proposed, the other element of our proposal from January was that the per enrollee fees and the tiers could be modified by the administration as necessary to continue to meet the funding obligations, and obviously that was a concern that others had, that we would do that. We would obviously do that through, as we do things today, reporting through the estimate. Our hospital fee structure is structured so that if there is an ongoing hospital fee, we also have that ability. But obviously another option, if that was what was enacted, would be that it would require statutory change. With respect to how the structure was developed, it really was aimed first at how do we make sure we're achieving the funding goals that we need to achieve, the $1.35 billion. Second, how do we make sure we're doing that through meeting the federal obligations? And as you said, it would be ideal if we could structure a tax that doesn't have winners and losers, but the federal rules are specifically designed to require there to be winners and losers. We have that in all of our provider taxes that we have. Now, the level of the size of the winners and losers is dependent on sort of how the distribution of Medi-Cal is occurring across those providers. With health plans, we're in a situation where we have essentially half of the plans who are being taxed provide Medi-Cal services and half don't. And so that's very difficult to structure a tax that overall doesn't have, essentially half of the providers ending up essentially being losers. But the way that we looked at the structure then was, okay, how do we minimize the overall loss? That was really our third goal. So we know we wanted to meet the federal rules, but then we had an ability within that to structure something that would overall bring down the impact. As I mentioned, a specifically flat tax would have had a net impact of $950 million. The proposal we came up with is about $650 million. So the way we did that was to look at the enrollment levels of all the plans who would be subject to the tax and see if there was some common levels of enrollment, essentially size of plans who are Medi-Cal, because again, it's the easiest thing to tax. If we're taxing Medi-Cal plans more, they are able to receive the cost of the tax back. And so the structure was really developed that way, that how do we actually hit that essentially sweet spot of taxing as much Medi-Cal as we can while still meeting the federal requirements that you're not only taxing Medi-Cal. And the way we found to do that was that there are some very small plans who don't serve any Medi-Cal and would be disproportionately impacted if we had sort of the tax on essentially very small lives be very high. So we have a structure that has the first tier as a very low amount, about I think it's $3.50 per member month. Then what we also discovered was most Medi-Cal plans were sort of in that sort of smallish to medium size. So the next tier was a much higher amount. I believe it's in the $25 range. And then we went down from there. And that really was, again, trying to target the Medi-Cal plans and not have disproportionate impacts on either side, where either very small plans or very large plans would be paying a disproportionate amount of the tax. Again, that was based on our goal of really trying to get to the lowest overall net impact without having huge disparity, although 0 to 4% certainly is an amount of disparity. And then in terms of the question of offset, one of the federal requirements is that you can't hold plans harmless. So even if it was completely unrelated to the tax, there can't be indirect or direct hold harmless requirements. So if, on the one hand, we had a statute that enacted a tax of this nature and then had a different action that gave money to commercial plans who were paying the tax, that would be viewed as an indirect or direct hold harmless, and that would make the whole tax impermissible according to federal Medicaid law.
We earlier had a presentation from the LAO's office that looked at a couple of the healthcare-related taxes that currently exist. One, of course, is the MCO tax. There's also the skilled nursing facility tax and the hospital fee. Are there other potential healthcare-related taxes that we don't currently have in California? And is there any thinking being done on altering any of the other existing healthcare-related taxes that are not MCO taxes?
Sure. So certainly it is allowed under federal law to tax other providers of health services, for example, physicians, transportation providers, just to name a couple. I know that in the past there have been at least certainly some attempts to look at those types of taxes, the challenge being this issue of winners and losers. And the same situation that we're facing with the health plans, we would face with providers such as physicians or transportation providers where there's a disparate spread of Medi-Cal membership, where you have significant numbers of providers who do not treat any Medi-Cal, and you have significant providers who have a large business of Medi-Cal. And so that is always where the struggle is, and so we would face the same struggle that we're facing with the plans, but certainly those are options if those were things that folks wanted to look at. The reason we don't face as much of a challenge with the two that we have, the hospital tax and the nursing facility tax, is because with those types of providers, you actually don't see as much of a disparate spread of Medi-Cal membership. So all hospitals treat Medi-Cal to different degrees, of course, but there is not a hospital who has zero Medi-Cal. So it's obviously very different from our health plans. And then very much so with long-term care facilities, as had been mentioned by the LAO, Medi-Cal is actually the largest payer of long-term care, and so, again, not as much of a spread of sort of percent of business that is Medi-Cal, and so it's much easier to find a tax that, while, again, there still are losers, it's not to the degree, the spread is not as large. And then, no, right now there is not any plans to look at changing either of those taxes. Obviously, we just reauthorized the nursing facility tax as a part of this last budget.
Assemblymember Bonilla.
I don't know if this is the appropriate time to raise this issue, and I hesitate to raise it, but our nonprofit hospitals are tax exempt from property taxes, and they do a wonderful job in community benefits. But for a long time, I think there's been some interest from when I was on the Board of Supervisors and now even here and from other folks about maybe more closely analyzing that situation for the benefit of our entire medical system. And so I don't know what that amount is in terms of uncollected taxes that is there. And I'm not saying they're not spent, because I know they are spent in the community. But when we come to a place where we have to prioritize, maybe that's something we need to be also looking at. But I'm not sure if that would be a different revenue. It wouldn't be part of this, but it would be coming into the general fund to address this issue. Is that something you've looked at all?
It's not something we specifically looked at.
And is it something that makes any sense, or is it just a crazy idea?
I wouldn't judge that myself.
You're so kind. Thank you.